A very good evening to all of you, my respected colleagues, seniors, and I would like to welcome you on this very special webinar organized by CCI on the eve of Women's Day. Well, why is it very special? Because this theme of Women's Day is to invest in women and accelerate progress. So the idea of this webinar has been given by a woman, and we have two women panelists with us to increase our knowledge about this. And it's a very common topic, something which we as clinicians, as chest physicians, day in, day out, deal with subconsciously. But we are so proud that one of our fellow panelists had an query. She came up with an idea, and it made us do this particular webinar to enlighten us more on the very commonly used inhaled corticosteroid and LABA combinations. Now, it is not a hidden secret. All of us in our clinical practice face this scenario of making a choice ki what to use, kab use kare, kya use kare, kyo use kare. So we have tried in this webinar to bring together views from all over India. We also have an esteemed pharmacologist with us to help us understand and make a better choice in patient interest. What are the pros and cons, mechanisms of action? So I would like to introduce my panelists, my fellow panelists, before we go on to three very interesting talks on the subject. I would like to begin with introducing Dr. Sakshi Batra from Hyderabad. She is an assistant professor at Malla Reddy Institute of Medical Sciences. And I would like to credit her with the idea of this particular webinar. So welcome, Sakshi, to today's webinar.
Thank you, sir. Thank you so much for the wonderful introduction.
We have from Kerala, we have a very special Dr. Nisha Mathew, who is an associate professor at Zion Medical College and also a consultant pulmonologist at Pandalam Hospital. Then we have the very smart and dashing Dr. Abhishek Tandon, who is an associate consultant. Sir is MD/DM, and he works at the Medanta Institute at Lucknow in the Department of Pulmonary Medicine and Critical Care. Then we have Dr. Subhankar Choudhury, who is an associate professor and is currently based at Rourkela. I am very obliged. Dr. Subhankar was busy taking an exam in Cuttack, but he has joined, and we all five of us together for the past few days have been pondering on this subject. Now, without wasting any more time, I would like to hand it over to Dr. Sakshi to begin with her presentation on the history of inhalation therapy.
A very good evening, everyone. Always listening to CCI ever since I was a resident and sitting here as a panelist, I really feel grateful. First of all, I would like to thank NH Krishna sir, Narayana Pradeep sir, Atri sir, Ravi Dosi sir, Vijay sir, Shivani ma'am, and Kirat ma'am to give me this opportunity to be on the platform. So today the topic is history and evolution of the inhalational therapy. Now coming to my slides, the delivery of therapeutic vapors through inhalation has been used for thousands of years, dating back to 1500 BC in various cultures. The first known reference to therapeutic aerosol delivery is an ancient Egyptian papyrus scroll. This papyrus basically describes the patients struggling to breathe to inhale the vapor formed when with the black henbane, that is nothing but Hyoscyamus niger plants, which were placed onto the hot bricks. You can see in this diagram here, after placing this herbs on this stone, a jar with a hole was placed over the herbs, and the patient inhaled the fumes through the stalk of reed that was placed onto this hole. The inhaled vapor of henbane plants was nothing but atropine. And the most prominent ancient form of respiratory drug delivery was the smoking of opium for therapeutic and recreational purposes. The inhalation of therapeutic aerosols prepared by herbal compositions of Datura stramonium has also been described in the writings of Charka and Sushruta for the treatment of asthma symptoms. Now, in addition to the Datura, it was not just the Datura. The Charka has also described the range of asthma therapies that included stream inhalation, and the cigars made up of turmeric, cinnamon, and even ghee, the red arsenic, has been also been used. Ephedrine, which was later isolated from ephedra by Japanese chemist remained widely used for the treatment of cough and respiratory disease until the 1950s, when it began to be displaced by the other bronchodilators. So here you can see the paid cigarettes which contained the stramonium and the tea leaves. So MTI initially was used for the administration of the non-selective beta agonist. That was nothing but adrenaline and isoprenaline. But there was an epidemic of asthma which occurred in 1960s, which was called as the British asthma deaths. It was then the short-acting beta-2 agonist, that is the salbutamol, came into the picture. Then talking about glucocorticoid, which is the most effective treatment for asthma, that is the cortisone, initially called the compound E, was extracted from adrenal cortex by the Edward Kendall in asthma, again used in asthma in 1950s. Within a few years of the first reports of the efficacy of the systemic steroids, it was when the prednisolone and hydrocortisone came into the picture. We all know oral corticosteroids are very effective in asthma treatment, but it could not be used because of the long-term side effects such as hypertension, osteoporosis, diabetes. And there was an initial efforts were also made to make the nebulization of hydrocort, which ultimately failed, and then led to the administration of the safer steroids, which led to the development of beclomethasone dipropionate in the 1970s. Now coming to the history of inhaler devices, the first inhaler was called the Mudge inhaler, named after the John Mudge in 1778. Basically, it was based on a pewter tankard that the inhaler allowed people to breathe in an opium vapor to treat. That was called a Catarrhus cup, a cup with a lot of mucus. Basically, to operate this inhaler, users used to pour water into the tankard, they close the lid and breathe in the steam through a flexible tube inserted into an opening in the cover. So here you can see this flexible mouthpiece. The air was drawn from these holes on the handle and the air was bubbled through the medicated liquid before exiting the mouthpiece. On the right side of my screen, you can see the valve configuration of this pewter tankard. Now, coming from portable nebulizers to the dry powder inhalers, the 1800s saw the invention of this first portable nebulizer that was called as the pulveristor. The pump handle forced a liquid solution through an atomizer to turn it into the vapor through a small nozzle and directed it into this impaction plate to produce a fine spray. Again, it was used for the treatment of pharyngitis, tuberculosis, and cough. Coming to dry powder inhalers, which became popular, again, one curious DPI was the carbolic ball, which promised to cure asthma in 10 minutes. So users used to squeeze this ball, you can see here, forcing a powder through a sieve and convert it into an inhalable spray. So father always can go to any extent when he loves his daughter. So this has been proved in the history of pulmonology. There was a 13-year-old girl, which was basically an inspiration for the discovery of the meter dose inhaler. The major breakthrough came in 1956 when George Mason, who was the president of the Riker Laboratories, invented the meter dose inhaler using glass vials and valves designed for the perfume bottles, basically. So it was Mason's daughter who inspired him for this invention. She was suffering from severe asthma and tired of her squeeze bulb glass nebulizer. This 13-year-old girl asked her father, "Why can't you put my medication in the spray? It's like perfume or the hairspray." Again, shocked by her question, Mason created the first MDI, and which was launched by the Riker Laboratories in 1956. So within the 2 months, the Riker Laboratories made the first MDI made up of epinephrine and isopropanol. And here you can see the first MDI which was being invented. So by 1980s, MDIs we know which came to the market had CFC as a propellant. And CFCs, but nothing, they used to break down and release the chlorine radicals that have the ability to break the large number of the ozone molecules. So it was 1980s, the mid 1980s, when the stratosphere ozone levels were depleting at an alarming level. When in 1987, the Montreal Protocol was signed and they called off for the elimination of the CFC propellants. Now coming the propellants for tomorrow, that is nothing but HFO, tetrafluoropropene and difluoroethane, which are known to be having a lower global warming potential, which is less than 1. So these are nothing but the propellants for tomorrow. That is the HFO tetrahydropropene, which have been coming, which are about to come into the market after the Kigali Amendment. So this was Sir David Jack, the former director of the Galexo, discovered the first beta-2 selective agonist, that is salbutamol, launched as Ventolin, the first inhaled corticosteroid beclomethasone, again the salmeterol, and the fluticasone propionate. So as I said, the father can go to any extent for the love of the daughter. Again, this was gel Ventolin, again who had a daughter who did not like the taste from the lubricant in the formulation, and she had a coordination issues with her inhaler. So it was when Ventolin discovered this turbohaler, and the first turbohaler product was approved in 1987, which was basically Terbutaline. So this is the history which I have been told you about, which I have already told you about the inhalational therapy. So I would like to end my slides, and the next presentation will be taken over by Dr. Mathew. Thank you so much.
A very warm good evening, dear CCI family. I am Dr. Nisha Mathew, working as consultant pulmonologist in CM Hospital, Pandalam, Kerala. First of all, I would like to express my sincere gratitude to all CCI organizers, Dr. N.H. Krishna sir, Dr. Narayana Pradeepa sir, Dr. Shivani madam, Dr. Ravi Dosi sir, Dr. Vijay Kumar Chenam Chetty sir for giving me this opportunity to perform this webinar. So now we heard a beautiful class on history and evolution of inhaled bronchodilators. I am going to talk about the classification and pharmacology of inhaled bronchodilators. Based on the mechanism of action, we have beta-2 agonists, anticholinergics, combined bronchodilators. Under beta-2 agonists, albuterol, salmeterol, formoterol, among anticholinergics, ipratropium and tiotropium bromide. Coming to the mechanism of action of beta-2 agonists. Beta-adrenergic receptors, these beta-agonists acts on the beta-adrenergic receptors, which are transmembrane glycoprotein structures that elicit a response inside the cell when interacting with catecholamines. They belong to a major receptor family, R7G, that contain other receptors too, and these receptors are coupled with guanine nucleotide protein binding proteins, that is G proteins. So what happens is when beta agonists bind to this beta receptor, alpha subunit of the G protein get detached and attached to the adenyl cyclase that again catalyzes the conversion of ATP to CAMP, which acts as a second messenger in the cell for this smooth muscle relaxation. So how does this CAMP helps in smooth muscle relaxation? Mainly by two mechanisms. It inactivates myosin light chain kinase, and as well as it reduces the influx of intracellular calcium. It reduces the intracellular calcium levels. Beta-2 adrenergic receptors are coded on chromosome number 5. The receptor is composed of 8 alpha helices, 3 are extracellular and 5 intracellular. It is bound to and transmit its signals inside the cell through this G protein, specifically GS protein. And GS protein, again, we have alpha, beta, and gamma subunits. We can again classify this beta-2 agonist as based on the duration of action, that is short-acting, long-acting beta-2 agonists, and ultra-long-acting drugs. Short-acting beta-2 agonists, we have albuterol, levoalbuterol, metoprolol, and terbutaline. Long-acting beta-2 agonists, that is indicated for the maintenance treatment of bronchoconstriction. Under that, formoterol, salmeterol. Ultra-long-acting beta-2 agonists, we have olodaterol and indacaterol. There are so many off-label uses also for these products, that is albuterol for hyperkalemia, by mainly causing the shift of the calcium, intracellular shift, and terbutaline is administered to postpone the preterm labor. Beta-2 agonists are mostly given in inhaled forms, whether as a spray or a nebulized form or MDI, DPI form, to limit the systemic adverse effects and reduce the delivered dose to target only the respiratory system. They can also be given intravenously or intramuscularly in severe acute exacerbations of asthma. Metabolism is by the enzyme cytochrome P450 in the liver, and it is excreted primarily through kidneys. What are the common adverse effects? There are usually no side effect with our usual dose of short-acting beta-2 agonists. If at all it is there, then most common is tremors, anxiety, palpitations, tachycardia, Elevated SABA doses can produce lactic acidosis, reduced level of potassium, magnesium levels, and hyperglycemia. LABA can cause cardiac arrhythmias and muscle cramps. So systemic exposure to beta-2 agonists can cause vasodilatation, leading to hypertension and can potentially trigger headaches. Hypertension may also cause hypoxemia due to ventilation perfusion mismatching in the lung. The risk of myocardial infarction was found to be 7 times higher in patients using beta-2 agonist compared to those who are not using it. And contraindication, obviously, hypersensitivity to this molecule, we should not give this. Cardiac arrhythmias, ischemic heart disease, hypokalemia. Usually, we don't need any monitoring for these beta-2 agonist levels, but if at all needed, then gas chromatography or liquid chromatography with mass spectrometry, fluorimetric detectors, and electrochemical detectors. Coming to the toxicity, this beta-2 agonist toxicity can be accidental or intentional. As we already said, most dangerous complication is hypokalemia, significant hypotension. It can even produce supraventricular tachycardia, extrasystoles, tremors. Very high doses can lead to psychosis and hallucinations. Coming to the second group of drugs, that is inhaled anticholinergics. These are the anticholinergic medications are drugs that block and inhibit the activity of the neurotransmitter acetylcholine at both central and peripheral nervous system. We have short-acting inhaled anticholinergics and long-acting inhaled anticholinergics. Short-acting ipratropium, oxytropium, long-acting tiotropium, glycopyrronium. Coming to the mechanism of action of anticholinergics, basically this cholinergic system utilizes 2 types of receptors, muscarinic receptors and nicotinic receptors. Anticholinergic predominantly affect the muscarinic receptors. These drugs can actually treat a variety of conditions from overactive bladder to chronic obstructive pulmonary disease, and it has obviously have a wide range of physiological effects, including effects on circulation, respiration, alertness, and vision. Adverse effects, it has got central and peripheral adverse effects. Central effects result from the excess blockade of cholinergic receptors within the central nervous system. Most common headache, impaired memory, reduced cognitive function, behavioral disturbances, anxiety, and insomnia. With high doses, we have agitation, confusion, delirium, and seizures. Peripheral adverse effect mainly result from the blockade of exocrine glandular secretion, muscle contractions. So in general, we have hypothermia, anhydrosis. In cardiovascular system, tachycardia, flushings, arrhythmias can occur. Gastrointestinal, we have reduced gut motility leading to constipation. Genitourinary, urinary retention can happen. Blurred vision, mydriasis, narrow angle glaucoma, and potential vision loss can also happen. Inhibition of sweating and diminished muscle contraction. So these are the various inhaled corticosteroids we have: fluticasone, HPA, beclomethasone, budesonide, mometasone. Mechanism of action, it actually acts via up or down regulation of gene transcription. When glucocorticoids, it interacts with the glucocorticoid receptors which is present in the cytoplasm. It actually diffuses through the cell membrane and interacts with the receptors in the cytoplasm. It can cause activation and repression of various transcription factors. You can see the reduced transcription of various inflammatory cytokines like IL-2, IL-3, IL-4, and reduced transcription of chemokines like IL-8 and reduction of inflammatory enzymes. It also interacts with the pro-inflammatory transcription factors, which will produce less amount of pro-inflammatory genes. All these will lead to reduced inflammation. Bioavailability of inhaled glucocorticoids varies with specific agents that differs with the various agents, especially lipophilic drugs like fluticasone, beclomethasone has got low oral bioavailability. Overall absorption of inhaled glucocorticoids varies between 20 to 40%. Around 60 to 90% of dose delivered from a mid-dose inhaler or DPI deposited in oropharynx, that is, this undergo first-pass metabolism in the liver by CYP3A2 enzyme. 10 to 40% of a dose from MDA enters the lung. and that too varies with various molecules. Like cyclosinide has 60% delivery to lungs, whereas beclomethasone HFA has 55 to 60%. Mometasone and fluticasone propionate HFA has about 80% delivery, whereas in case of DPI, that is budesonide and fluticasone dipropionate, has around 15 to 30% lung deposition. Medications that inhibit cytochrome P453A4 has the potential to inhibit the metabolism, to impair the metabolism of inhaled corticosteroids that increases the serum level. Co-administration of budesonide with itraconazole, it can cause adrenal suppression. Likewise, along with the co-administration of fluticasone propionate with ritonavir, it again has a possibility to develop iatrogenic Cushing's syndrome. Adrenal suppression usually is seen with systemic administration of glucocorticoids, that it can cause HPA suppression, and it is rare with our inhaled corticosteroids. There are two main enzymes involved in the metabolism: 11-beta-hydroxysteroid type 1 isoenzyme and 11-beta-hydroxysteroid type 2 isoenzyme that converts inactive cortisone to active cortisol, type 1 isoenzyme, whereas type 2 convert active cortisol to inactive. Ultimately, glucocorticoids converted to hydrophilic inactive metabolites and renally excreted. Coming to the adverse effects, there are local adverse effects like dysphonia, oral candidiasis, reflex cough, and bronchospasm. These adverse effects are less common with low-dose inhaled corticosteroids, as well as it is very low if we use MDI with spacers. Systemic adverse effects, we can sometimes see cataract, glaucoma, hypothalamic pituitary adrenal axis dysfunction, impaired glucose metabolism, and sometimes infections, bacterial infections, pneumonia, tuberculosis, NTM infection can happen, osteoporosis and fracture risk in adults. So all these so many researches are going on, whether these inhaled corticosteroids actually causing this in high dose level. So, coming to the contraindications, hypersensitivity to the medication and severe hypersensitivity to milk protein or lactose. Dry powder inhalers often contain lactose as a stabilizing agent. And for severe infection also, we should have precaution before using these inhaled corticosteroids. Thank you. Next, the combined steroids, combined in bronchodilators will be taken by next person. Thank you.
Good evening. At the onset, I would like to thank the organizers of CCI for inviting me to this webinar today. My talk has been made very easy by Dr. Nisha, who has so beautifully categorized and summarized the pharmacology of all the inhalational therapy that I'll be going to talk about. So the topic that has been given to me today is the landmark trials of inhalation therapy in OAD. And I'll try to do justice to this topic in the next 10 minutes or so. So my talk has been divided into two parts. At first, I'll be covering the trials in asthma, and then I'll be moving on to the trials in COPD. So as we all know that oral corticosteroids have been used for the treatment of asthma since a very long time. But some of us would be very surprised to know that they were given upfront to patients with asthma before the advent of inhalational corticosteroids. And this was the scenario till around the 1970s, when a series of studies started popping up. One such study was by Dr. Davis, who in 1977 hypothesized, what if we give an inhaled corticosteroid to patients who have been dependent on oral corticosteroids? And to his surprise, he found that there was a significant diminution of symptoms, reduced medications, and improved maximum expiratory flow rates. And what surprised him the most was that at least 50% of the patients were able to discontinue their oral prednisolone, and about 1/3 could reduce their dose by 50%, which was an achievable, which was a remarkable feat at that time. Now, the story of asthma management, as we all know, till 2019 was budesonide for maintenance, and salbutamol was used SOS for the relieving of symptoms. But what changed in 2019? Do we know the story behind it? In 2019, GINA came up with its updated treatment module, which completely revolutionized the treatment of asthma as we know it today. They recommended ICS formoterol for step 1 and step 2 treatment on an SOS basis. But what caused this? Since 2017, GINA has been actively seeking interventions for mild asthma to reduce the risk of asthma-related exacerbations and death and to avoid establishing patient reliance on SABA. And this search culminated with the SIGMA studies. Now, the SIGMA 1, published in 2018, compared inhaled combined budesonide and formoterol as needed in patients with mild asthma. And they concluded that in patients with mild asthma, as needed budesonide and formoterol provided a superior asthma symptom control to as needed terbutaline, but then again it was inferior to budesonide maintenance therapy. To address this conundrum, the SIGMA 2 trial came into existence, which compared as needed budesonide and formoterol versus maintenance budesonide in mild asthma, and it concluded that in patients with mild asthma, budesonide formoterol used as needed was non-inferior to twice daily budesonide with respect to the rate of severe asthma exacerbations during 52 weeks of treatment. Now, what is the role of LAMA in asthma? The role of tiotropium in asthma, poorly controlled with standard combination therapy, was addressed in the PRIMO-TINA trial, which concluded that in patients with poorly controlled asthma, despite the use of ICS LABA, the addition of tiotropium significantly increased the time to first severe exacerbation and provided modest sustained bronchodilation. The Palladium trial then again brought into fray once daily FDCs of ICS and LABAs with mometasone and indaketrol, and it proved that it was non-inferior to twice daily combination of ICS and LABA in the form of an high-dose fluticasone and salmeterol for the improvement of FEV1. The Iridium trial, which then again brought into fray a once-daily single inhaler, mometasone, indaketrol, and glycopyrronium into fray, and it proved that it improved lung function versus ICS LABA combinations in patients with inadequately controlled asthma. So as we know it, the updated GINA guideline could well, in the step 3, 4, or 5, come up with a once daily combination of an inhaled mometasone, indaketrol, and glycopyrronium. Now, we move to the second part of my talk, which is the COPD trials. We are very well aware of the groupings in the new GOLD guidelines, Group A, Group B, and Group E. While we use a bronchodilator to treat our COPD patients in Group A, the question which was persisting in the minds of almost all the pulmonologists was which bronchodilator to use, whether we should go with an upfront LAMA or with an upfront LABA. This question was answered by the POET COPD trial, which compared tiotropium versus salmeterol for the prevention of exacerbations of COPD, and they proved that tiotropium increased the time to the first exacerbation by almost 40 days, a 17% risk in reduction, and hence brought LAMA into the forefront. The SPARK trials eventually proved the efficacy of a LAMA-LABA combination over a LAMA, where it showed that a LABA-LAMA combination reduced the rate of moderate to severe exacerbations versus the LAMA by almost 12%. With the advent of the IMPACT trial in May of 2018, a once-daily single inhaler triple therapy was compared to a dual therapy of LABA and LAMA in patients with COPD. The IMPACT trial proved that the rate of exacerbations on a triple therapy was significantly reduced to a LABA-LAMA combination or an ICS LABA combination, but at the cost of a high incidence of pneumonia in the ICS group. Now, this led to the investigators to hypothesize that whether a lesser dose of steroid could do the same wonder a higher dose was doing, and hence the ETHOS trial came into existence, which compared a triple therapy at 2 glucocorticoid doses in moderate to severe COPD patients. And it proved that the rate of exacerbation in triple drug in both doses of budesonide was significantly lower than the ICS LABA or the LABA-LAMA combination. And hence came into existence the triple therapy for our COPD patients, where the eosinophil count is more than equal to 300, and where we are using a lower dose of steroid to treat the severe exacerbation phenotype. Then again, I would like to thank CCI, especially Dr. Krishna, Dr. Chanam Chetty, Dr. Ravi, Dr. Ratri for inviting me here today. I hope I've been able to cover what was expected of me, and I'll be happy to answer any questions during the panel. Thank you.
Wonderful. I think as far as we are concerned regarding inhalation therapy and in particular the LABA ICS combinations, I think we have got a very good overview as to where it started from Dr. Sakshi. What are the special indications, mechanisms, and side effects with Dr. Nisha? And Dr. Abhishek very correctly highlighted that what are the trials behind the scene which are actually making us use these and doing the betterment of our patients. Now, while introducing all of our panelists, I forgot to mention about two of our panelists who are invisible all the time, Dr. Narayan Pradeep and Dr. C. Vijay Kumar sir, who are there throughout this saga and help us day in, day out regarding all the webinars and all the stuff. So a big thanks and welcome to both of you too. Now, starting with this, I would like to bring in Dr. Subhankar, our in-house pharmacologist. That Dr. Subhankar, could you please unmute yourself? I would like you to, in a very, like we all remember our MBBS days where we were taught inhaled steroids, LABA, LAMA. So from a pharmacologist, I would like you to simplify this mechanism of action which Dr. Nisha has told us in such a detailed manner as to how we can remember this and apply it clinically, please.
Am I audible, sir?
Yeah, very much, very much.
Okay. Sir, if I go through the mechanism of actions and receptor, I will take a single line for each and every drug, just a single line.
Sure.
As far for steroid, we know that steroids are responsible for decreasing the mediators of inflammation. Two types of mediators are there, bronchoconstrictors and the mediators responsible for inflammations. For bronchoconstriction, two mediators are specifically responsible, sir. One is leukotriene and the second one is platelet activating factor. Both are secreted by mast cell and eosinophils. And rest of inflammation process are done by interleukins, eosinophils, and other inflammatory cells. Now, what steroid does? It inhibits leukotriene synthesis and platelet activating factor synthesis, as well as prevents migration of inflammatory cells from blood to the site of inflammation. Okay, so briefly, two mechanisms: bronchoconstricting mediators are not released, and inflammatory mediators and cells, they are not migrated. Okay, you give 2 points to the mechanism of action of steroid. Just give 2 points. Now, coming on to beta 2 agonist. What beta 2 agonists are done? What beta 2 agonists do? They bind with beta 2 receptor through G protein signaling, as Mathew madam has said. They will relax the bronchus. Okay. Relief from airway resistance. Give 2 points. Now 2 plus 2 is equal to 4. Okay.
Okay.
The result is 2 plus 2 equal to 5, like the movie Do or Do Paach in 80s. This is 2 plus 2 equal to 5, not 4. How? Like steroids increases the transcription of beta 2 receptors at nuclear level. More and more beta 2 receptors are available for the beta 2 agonist. At the same time, beta 2 inhibitory receptors are also present in mast cell and eosinophils. When salbutamol binds with mast cell and eosinophils, they decrease the release of leukotriene and platelet activating factor by inhibiting the inflammatory cells again through beta 2 receptors. So what is happening? Give 1 point extra for salbutamol. For adding the action of steroid and give 1 point addition to steroid for increasing beta 2 receptors transcription and leading to more and more binding on beta 2 agonists. So both are potentiating each other's effect. So this is not 2 and 2, 4. This is 2 plus 2 equal to 5 or equal to 6. This is synergism.
Excellent.
Okay.
Excellent.
Second thing, in COPD, LABA-LAMA combination. Okay. LABA, again, beta 2 agonist, inhibition of constriction, there is bronchial relaxation. And LAMA, inhibition of postsynaptic muscarinic M3 receptors, through which acetylcholine binds in larger airways. Larger airways thus gets relaxed. Give it 2 points. 2 plus 2 is equal to 4. Here again 2 plus 2 is equal to 5, not 4. Why? Because these beta 2 agonist drugs also act through beta 2 receptor in presynaptic ending of vagus and decreases release of acetylcholine, thus potentiating the action of LAMAs. So 2 plus 2 here is also is equal to 5. Another example of synergism. That's I want to conclude with all these things.
Very well said. And I think with our YouTube video being uploaded in some time, you will go down in the annals of history for explaining this so simply. 2 और 2 5, 2 और 2 6. Asthma COPD under control. Very nice. But now from Eastern India, I would like to move down to Southern India and Nisha madam. I will ask you a very practical question. See, the thing is that we are talking about LABA, ICS, we are talking about LABA, LAMAs, SITT. But tell me one thing, how do you diagnose your asthma patients and how do you justify inhalation therapy to your patients? Please guide me how you do it in Kerala.
I will always go ahead with asking history, a detailed history of variable respiratory symptoms, symptoms such as cough, shortness of breath, chest tightness, wheeze that vary over time and in intensity, and it is exacerbated with history of exposure to allergens, some simple viral respiratory infections, exposure to cold weather, like that. Even emotional stress, anxiety can also precipitate our asthma. And we have to document that, confirm the diagnosis with documented variable respiratory airflow limitation and documented excessive variability in lung function. Documented variability in lung function, when I say that, I will go for positive bronchodilator responsiveness, that is reversibility. After giving 200 to 400 microgram of salbutamol also, we again check the FEV1 value. If it is more than 200 ml increase or more than 12% increase, that is again good reversibility. And coming under that, we have twice daily recording of PEF value over a period of 2 weeks. If it is more than 12%, PEF value, if it is more than 12%, more than 13% in children, then that is also confirmatory for bronchial asthma. And positive bronchial challenge tests are there, positive exercise challenge test, positive exercise challenge test is there. And again, we have to confirm that with positive documented variable respiratory airflow limitation. When FEV1 value is reduced, we have to see the ratio. FEV1, FVC value is also low in these cases. So we have documentation is very important. Before starting any inhaled corticosteroid treatment, we have to confirm the diagnosis of bronchial asthma. Clinical examination, almost all time, the stable patients only come to see to our OPD. So chest may be normal. Sometimes we might hear bilateral respiratory wheeze. And for investigation purpose, spirometry, see for the lung function, and chest X-ray basically don't play so much role, but we can rule out the possibility of other probable alternative diagnosis like bronchiectasis, complications of asthma, even see for whether cardiomegaly is there or not, all those things. HRCT just also do not play so much role to rule out other diagnosis. We can go ahead with that. So basically from clinical history, examination, clinical findings and documentation with our spirometry, documentation of variable respiratory, variability in respiratory function and variable respiratory airflow limitation. Likewise, I diagnose my bronchial asthma patients.
But you are very smart, ma'am. You did not touch on the toughest part. How do you convince your patient for the inhalation therapy? That is what I want to know from you.
So I regularly explain all my patients the importance of inhaler therapy. Inhaler therapy remains the cornerstone treatment for our obstructive airway diseases because it directly targets the airway where our medicine is required and needed, and minimum side effects. Systemic side effects are very less because it directly goes to the respiratory tract, and we will get the maximum therapeutic benefit with minimum side effects. Likewise, I used to explain my patients and always demonstrate the technique. Proper inhalation technique is very important in demonstrating this inhaler therapy, and always ask them to rinse their mouth and throat after using this in order to prevent further complications. Likewise, I explain all my patients.
Right, ma'am.
During every visit, each and every visit, I reassess the importance, whether my patient is compliant to my treatment or whether the patient is taking inhaler correctly or adequately, and whether there are any side effects or whether there are any complications apart from this. Also, comorbidities part also I will take care of. All these things I should cover in my treatment.
Excellent. Actually, means your statement gives a testament to the fact that asthma is not just write an inhaler. It is demonstrating an inhaler, explaining an inhaler, and ruling out other things also. So you can never say that asthma management is just like that and inhalation therapy is joke. It is definitely an evidence-based science, and it has to be dealt with in a very, very careful and personalized manner. At the fact part of our webinar, all of us will also be demonstrating for the first time how to use a DPI, MDI, and even all those actuated breath inhalers which are available. So that will also be an interesting part for learning. Now, coming down to Abhishek, I would like to ask you, Abhishek, you told us that Gina has made a very, very big change in the asthma management. And coming to our topic of LABA ICS, what is there in LABA ICS regarding the GINA changes which are taking place, and how does GINA guide us to use LABA ICS?
GINA has been recommending 2 tracks of treatment. The track 1 treatment is for those countries where an ICS formoterol combination is available, and GINA recommends that almost every asthmatic patient is given this treatment. So for step 1 and step 2, it recommends that we give an ICS formoterol in a low dose on an SOS basis. For step 3, it says that we give an ICS formoterol as a maintenance, that is in a BD dose. For step 4, it says that we give an ICS formoterol in a medium dose as a maintenance therapy, and then again in a low dose as a reliever. And then again for step 5, we give an ICS formoterol in a high dose as a maintenance therapy, and low dose ICS formoterol as a reliever. And then again we can go on to add a LAMA or then phenotype asthma, and then go ahead with the biologicals. Now coming to track 2, there's been a major change in the GINA 2023 guidelines, where they say that instead of using a salbutamol SOS, we should use a salbutamol with an ICS SOS. So in the maintenance, we're taking in a budesonide. For the maintenance therapy, we're using an inhaled corticosteroid, and even for a reliever, we're using an ICS with the SABA. So this has been the major change in the 2023 guideline, and it has gone one notch ahead of the 2019 guidelines.
But Abhishek, but I would like to really want you to draw our students or our audience today to one fact, that with the whole market being flooded with several combinations, isn't it a fact that if we keep on increasing the dose, then we can keep on managing our patients with the same thing?
No, sir, I would disagree with that. The thing is, when we increase the dose of ICS, Gina specifically says that increasing the dose of ICS doesn't give us any further benefit. Like, for example, if you're using a low dose ICS LABA combination, a medium dose or a high dose LABA combination doesn't help. And that is why with the iridium and the palladium studies that have come into fray, they're using an upfront triple drug combination of an ICS LABA LAMA for step 3 onwards, and which has proved its superiority over an ICS LABA. So I would recommend you go with an ICS LABA LAMA rather than going to a medium dose or a high dose ICS, which increases your chances of getting an adverse effect in the form of a pneumonia and serves a very little benefit.
Yeah, so that is one very important point, because see, first thing which Nisha ma'am very clearly alluded is convincing the person for an inhalation therapy. Second is the steroid part of it. Third is escalating the dose. And fourth is asking him to buy a new inhaler when the old dose doesn't work. So there are several aspects which require a lot of personalized touch. So really, at times this becomes difficult. So, Dr. Sakshi, I would like to ask you just to deliberate that how is this involved from different ICS LABA inhalers to combinations? What is your take on it, and what would you like to tell us about it?
Okay, sir. So basically, because I covered the history part, I would again like to come back to the history, how it got evolved is. So there was a salmeterol multi-center asthma research trial in 2000, basically in 2003. What they found was that people were taking their LABA inhalers very nicely, but they were not taking their ICS. So what created because of that was there were lots of asthma-related hospitalization, intubation, and death. So it was basically because people are using more of their reliever medications and they're not using their ICS medication. It was then that FDA started a black label warning, and they said that we should ban all the ICS and the LABA inhalers. So this is a very, all the people should know about it. It was then in 2017 when the FDA again started, because there were 4 bigger trials which were conducted, and 2 were Austri and the Westri trial, which said that the combination of ICS and LABA, in fact, reduced the exacerbations, and there was improvement in the trough FEV1 also. Again, the ICS LABA started coming into the picture. So it was Jan Trofast in 2000 who first made the combination of the formoterol and the budesonide in the form of a turbo healer. Now, as Subhankar sir has very beautifully said, why ICS and LABA are combined together is, we know ICS suppresses the chronic inflammatory process in the asthma, and they also reduce the airway hyperresponsiveness. Whereas the beta-2 agonist, apart from being a bronchodilator, they also inhibit the mast cell release, and they also prevent the plasma exudation apart from their bronchodilator action. So these two complement the effect of each other. It is said that people who use more of LABA, there are beta-2 receptor desensitization which occurs. So corticosteroids, ICS, will basically prevent this desensitization, and the loss of the beta-2 agonist with the chronic use is prevented by the use of the ICS. And in a similar way, beta-2 agonist potentiates the anti-inflammatory action of the inhaled corticosteroids. So these both are very good together, and they complement the effect of each other. And moreover, giving patients separate inhaler ICS and giving a separate LABA, it's better that we combine them together. It is cost effective, easy adherence to the therapy is there, and it is more convenient for the patients. One more thing I would like to tell here is that ICS formoterol, of course, we know it reduced the exacerbation by 60 to 64%, as it was shown in the Sigma 1 and the Sigma 2 trial, when they compared it with the ICS SABA usage and just a low dose ICS when it was used. So Sigma 1, Sigma 2 trials have also shown that ICS LABA combination is better than using just a low dose ICS or just using a LABA.
Right. But you have actually justified very well that while the combination is very important, but off and on, we still keep on seeing patients who are coming from several aspects of society, still using their old SABAs and individual ICS inhalers. Particularly, I find this usage quite rampant in the pediatric population who are being prescribed this thing. A lot of use is there of individual, although recommendation in track 2 is there, but still there is a lot of awareness which needs to be created about the advantage of LABA ICS combination. So, Dr. Nisha, you had told me that every time you demonstrate to your patient the LABA, the use of the inhaler, the side effects of LABA ICS combinations and any precautions that your patients should take. Could you highlight anything about that? Please unmute yourself. Please unmute yourself.
Sir, when I say about the side effects, I always tell my patients, usually with our routine dose of medication, they don't feel any sort of discomfort. But if at all it is there, side effects like tremors, tachycardia, cardiac tachycardia, that too resting sinus tachycardia, those tremors, which is dose limiting side effect, cardiac arrhythmias, muscle cramps, headache, dizziness, nervousness can happen with our beta 2 agonist. Coming to inhaled corticosteroids, local side effects are there like dysphonia, oral candidiasis, cough reflex sometimes can happen. Then perioral dermatitis sometimes can happen with, that is erythematous, eczematoid lesions over the around the perioral cavity or around the perilabial area, perinasal area, all those things. That is allergic contact hypersensitivity can sometimes occur. Tongue hypertrophy, that is very, very rare. I haven't seen any those complications in my OPD till now. And sometimes patient may have increased thirst. Coming to systemic complications, patient may develop cataract, that too posterior subcapsular cataract, glaucoma because of this anticholinergic medicines. Systemic glucocorticoids, as we all know, high doses, it can cause hypothalamic pituitary adrenal suppression, HPA axis suppression, even though it is rare with our inhaled corticosteroids. But I just give my patients just aware of all these things before starting inhaled glucocorticoids. And sometimes patient may develop impaired glucose metabolism. So once in a time, I will check his or her glucose levels also when I start my patient on inhaled therapies. And coming to infection part, sometimes patient may predispose to develop, as Dr. Abhishek has said, bacterial infections. Patient has a chance to develop pneumonia, if tuberculosis, non-tuberculous mycobacterial infection, all those things can happen when we use inhaled corticosteroids. But too, that is very rare in my routine OPD practices. And many researches have been going on whether our inhaled corticosteroids in high doses are causing all these complications. Some researchers have said that myopathy, skeletal muscle weakness, skin bruising, osteoporosis, risk of fractures, especially in adults. And certain studies in children, certain growth deceleration. But even with asthmatic, uncontrolled asthma itself produces growth deceleration. Certain studies have shown out that inhaled corticosteroids can increase the puberty time, that they grow very faster, increase the puberty time, and there is a growth deceleration. And certain psychiatric effects also can happen, like emotional liability, euphoria, depression, aggressiveness, insomnia, all those can happen with inhaled glucocorticoids. So these are in common, I tell my patients.
Okay. Amazing. Even after telling so much to the patient, if that guy takes up the inhaler, then really your convincing powers are beyond par. But but still, see, how so many side effects, Dr. Nisha, you may tell. The thing is that we have to use LABA ICS. Now, Abhishek, मेरी हिम्मत बढ़ाओ. बताओ how to optimize LABA ICS so that I can control asthma of my patient.
The most important part is not prescribing LABA ICS, is to actually ensure that the patient is using the LABA ICS combination. So first of all, when we used to manage asthma long back, we used to say that they need to take an ICS whenever they take a LABA. And we saw that they were not doing that and they were resilient on their Sagas. Then came the ICS LABA combination, which we now give twice daily. With the Sigma 1 and the Sigma 2 studies. And there's certain patients who come and say that, sir, it's a very hectic thing to take the inhaler twice a day. And can you give us something that we take once a day? So then came the Palladium trial, which has shown that a once daily mometasone and an indacaterol combination is actually non-inferior to the ICS formoterol combination. And so we can offer this combination to our patients and say that, dekho bhai, you just have to take it once in the morning, once you wake up, and you're done for the day. And you'll be just going forward. And then again, we have to actually ask the patients to show us how they're taking the inhalers. If they're unable to take a DPI, we should convert them into an MDI. If they're unable to take both a DPI and an MDI, we should put them on a nebulization therapy for the time being, and in the meanwhile, train them to optimize the use of a DPI and MDI. So basically, it has to be a combination. We have to ensure that the right drug, the right instrument is being prescribed to the patient, so that the actual dose that we want him to take is being taken by the patients.
No, very beautifully answered, and I do agree that your advocacy of a single inhaler therapy for patients not satisfied with LABA ICMS is very much justified now. But I would like to ask an opinion to all you three who are here, who are clinically practicing. In the market, there are several combinations where the dose of the LABA also goes up. The double dose LABA is available. So, and there are situations where you go from a 200 of budesonide to a 400. So, just tell me, let's say, Dr. Nisha, in which patient will you go for a higher LABA, and in which patient will you go for a higher ICS, given that only a LABA ICS is available to us? Unmute yourself. Unmute yourself.
For especially for LABA ICS, inhaled corticosteroids, especially I go ahead with if blood eosinophil count, if it is more than 300 cells per microliter, and issue of previous exacerbations, recurrent exacerbation patient might be having, and its lung function values are declining. So obviously we have to increase the dose of corticosteroids. Whereas in case of recurrent pneumonia in the previous year, in that case, we should not escalate the level of inhaled corticosteroids. Long-acting beta-2 agonists, we should increase.
Very nice. So, very nice. This is just a comment. I'll just keep this short. Abhishek, aap boliye ki when will you increase the dose of LABA in your patients? Any select category in which you feel that giving a higher dose LABA might help?
Patients who've been experiencing significant side effects of an inhaled corticosteroid therapy, maybe an oral thrush, maybe a glaucoma, maybe a cataract, or maybe an osteoporosis, which rarely is documented in theory, but I've seen 3 of my patients having it. I would want to escalate the LABA component of the ICS LABA therapy rather than the ICS. And any other patient who's tolerant, it's always the ICS component that has to go.
That has to go. Very nice. So, Dr. Sakshi, I would also like your view on what I asked to Dr. Nisha and Dr. Abhishek. But at the same time, I would also like you to describe what is this galaxy of LABA and ICS that we are always having in India. Our American counterparts are always saying कि यार there are 1, 2, 3 तो है उसमें इतना discuss क्या करना है? They say it in English, but I am asking you, what is this galaxy of LABA ICS which is available in India?
Okay, so coming back to the previous question which you asked, sir, see, when we are talking about a COPD patient, we all know we start with a bronchodilator, and inhaled corticosteroids comes in the E category. So I would like to increase the dose of the LABA when I'm talking about the symptomatology of the patient, especially in the COPD when I talk about. Adding a ICS is basically when you are thinking that the patient is exacerbating more, then I would like to add a ICS. But for a COPD patient, when I'm talking about the A and B category, and as Dr. Abhishek Tandon already sir said that, if the side effects are increasing with the steroid, then we would like to taper the dose of the steroids, and rather than adding a LABA is better. Now coming to the other question, what are the different LABA ICS which are available in India? So I will basically, to simplify my answer, I'll be talking all the combinations which we have with the LABAs first, like formoterol, what we have. With the formoterol, we have a budesonide combination. So we know formoterol is available in the 6 and the 12 microgram. Also, if I talk about the turbohaler, 4.8, we have the formoterol, and 4.8 and the 6. Sorry, 4.5 and 6. In the budesonide, in the turbohaler, we have 80, 160, 320. Whereas a normal pressurized MDI, we have 200 and the 400 microgram. So formoterol with the budesonide combination is the one. Then we have formoterol with fluticasone propionate combination. Then we have formoterol with beclomethasone combination also. And formoterol with the mometasone combination also is available. Talking about the salmeterol xenophosphate, we have salmeterol with fluticasone propionate combination. And indaketerol acetate we have with mometasone. Indacaterol we also have with budesonide combination, and bilateral triphentate we have with the fluticasone furoate combination. Here I would literally like to point is that when we talk about fluticasone, we have two esters. We have a fluticasone furoate and fluticasone propionate. So what I'm talking with bilateral is we have a fluticasone furoate combination, but with formoterol and salmeterol, I have fluticasone propionate combination. Now, again, anyone may ask what is the difference between the two. So it was found that fluticasone furoate is more better, and it was having a higher affinity for the nasal and the lung mucosa. Again, coming to the indacaterol, when I talk about indacaterol, we have indacaterol maleate and we have indacaterol acetate. So when I talk about indacaterol and mometasone combination, we have indacaterol acetate. And when I talk about indacaterol and budesonide combination, this one thing I would like to tell is indacaterol budesonide combination is recently approved, and it was just the Zydus which has got the, the marketing has been, it has started the permission, it has been got by the Central Drug Standard Control Organization. It is recently 2021 only that they are coming with the indacaterol and budesonide combination. So again, coming back to the previous thing, indacaterol maleate and indacaterol acetate. Indacaterol acetate is the combination which we have with the indacaterol acetate is the combination. Indacaterol maleate and acetate, which I said, maleate is known to be more better as compared to acetate, and maleate has more side effects of cough as compared to the acetate. I hope I haven't confused everybody.
No, not at all. In one OPD, when your session of the pharma starts, you have 10 people explaining you the same thing every day. We don't get confused then. So how can you confuse us? You have rather highlighted the fact that we have several combinations available, and it is very important to even pay attention to the surname of the inhaler. आप सिर्फ फ्लूटिकासोन मत जाइए, इंडाकेटोल पे मत जाइए. The thing behind that also carries relevance, and any and every combination which is being brought to you has been tried and tested. So that is why I would like to now call upon Dr. Subhankar. Dr. Subhankar, can you just tell me a bit about the trials of these LABA ICS in asthma? Like Dr. Sakshi has illustrated a huge galaxy that we have available. Anything important pharmacologically that you can tell us about?
I have little things left in my pitara. Abhishek sir, Sakshi ma'am, and Mathews ma'am have covered 99% things. I just will conclude with few points only. After studying maximum Cochrane reviews, meta-analysis, I can only say, if I tell about beta-2 agonist, patient compliance is one of the important factors that we consider. And for that, I will say fastest acting drug, that is formoterol, is our choice. But if we think for long-term safety, then salmeterol is the safest one. But we will, as per LABA, we will proceed towards formoterol as the quick relief is experienced by the patient. And in longer duration, after a longer time, that is after 1 year or 18 months, the formoterol side effects are also very dangerous. Palpitation, tremor, tachycardia, everything that happens with salbutamol, same happens with this formoterol. The serious consequences of one of the side effects is hallucination and nervousness and mood swing. Even a single mood swing can exacerbate the attack of asthma, new attacks. And this is found in many cases has been found with formoterol during its long-term therapy. And that's why to prevent these triggers, you need SABA to control these unusual effects of formoterol. Coming on to, sir, inhalational steroids, the safest one is cyclesonide. All Cochrane reviews and meta-analysis, the safest one is cyclesonide. Eosinophil count is significantly reduced by budesonide and fluticasone. Budesonide, I will give 2 points more. And as far as anticholinergics are concerned, aclidinium and glycopyrronium, the most safest one as compared to IPRA and tiotropium, as tiotropium bromide has some effect on respiratory clearance, and dryness may lead to secondary infections. So I can overall say that formoterol is our the drug of choice, the LABA of choice, and this budesonide and cyclosonide will be preferred over other inhalational steroids.
Right, very nicely summarized. You talked about a lot of very much proven stuff from Cochrane, how one beta 2 agonist stands apart. But there is one thing which is of huge interest. In fact, our question box is flooded by iOS findings of small airway disease and some specific use and recommendations. So I would like to ask you, Dr. Abhishek, what is this small airway disease, and is there any separate inhalational recommendation for this?
Sir, the airway which is less than 2 microns, we classify it as in small airway. So basically, theoretically speaking, when we use an ICS LABA combination, what happens is that the size of the particles is between 2 to 5 microns. So theoretically, the drug never goes to the small airways and it's deposited in the large and the medium size airways. So this problem was overcome by a company which came up with an ultra fine ICS LABA combination in the form of a formoterol and a beclomethasone MDI. They delivered a MMED of less than equal to 2 microns. So hypothetically, on paper, it should have had gone to the small airways and provided greater benefit for patients with a small airway disease. But a lot of studies, especially by Dr. Barnes et al., who's worked a lot on small airway diseases, has shown that actually this ultra fine ICS LABA combination doesn't help much over the regular ICS LABA combination, because these particles that are less than equal to 2 microns, they go in and out of the small airways without actually being deposited. So it's still early to comment upon it, but yes, to answer your question, yes, a separate inhaler with an ultra fine particle size is present to treat the small airway phenotype of both the asthma and the COPD and the small airway diseases per se, but practically the effects are yet to be seen, sir.
Right, so it makes...
And so before I move on, Dr. Krishna has ordered me to announce it on the webinar that we've had more than 1153 logins, and he's very proud of the entire CCI family for logging in here today.
Great. That's great. More than 1,000 people. It's amazing. So very nice. And actually, Abhishek, why will they not log in? Because after all, for every pulmonologist, LABA ICS is bread and butter. We need to know it in and out. History ho, current ho, ya future ho. LABA ICS is one thing which we should be very thorough about. Yeah. Another thing which we should be very thorough about is how to smartly treat our mild to moderate asthmatic cases. So, Dr. Nisha, you talk to a lot to your patients, you do everything with them. Just tell me, what is this smart therapy? What is smart?
So actually, this smart therapy is single maintenance and reliever therapy. That is, we combine two bronchodilators, that is beta 2 agonist, long-acting beta 2 agonist, and inhaled glucocorticoid in a single inhaler, so that our patient will get the maximum benefit. That is, anti-inflammatory part is covered and muscle relaxation is also there. So we are giving them a double benefit. So nowadays, Gina also recommended that this smart therapy, that is long-acting bronchodilator along with inhaled corticosteroid, they actually provides immediate relief, rapid relief to exacerbation as well as in maintenance part. For Gina 1, Gina 2, that is step 1 and step 2, step 1 they give us as needed smart therapy, as needed, as and when needed, we can give ICS plus formoterol, like budesonide and formoterol. And for step 2, they are saying like maintenance ICS low dose ICS plus formoterol. And step 3 and step 4, it is maintenance. It is recommended to give this ICS formoterol combination as immediate relief and as well as maintenance. There are many trials also. One study, they have included around 700 patients. They have classified it as 3 arms, one using single short-acting beta 2 agonist, second one using SABA along with ICS, and the third one, this long-acting beta 2 agonist and ICS. And it has been found out that it has actually reduced the symptoms and reduce the frequency and severity of exacerbation. So, like Abhishek sir has said, instead of increasing the dose of ICS, we can actually reduce the dose of corticosteroids, inhaled corticosteroid, if we combine long-acting beta-2 agonist along with ICS. So, it is actually smart that we can control the symptoms as well as long-term maintenance. We can give the same therapy.
Very nice. Now, just tell me one thing. Like Dr. Nisha, I'll just want to ask you. In our group A to C COPD patients, what will you do? Like you manage mild to moderate. How about these group A to C COPD cases?
So COPD, again, like I said, inhaled bronchodilators are the cornerstone in the management of stable COPD patients. So actually, by managing COPD, we have to reduce the symptoms, reduce the frequency and severity of exacerbation, improve the health status, improve the lung function of the patient. These are our motto. Basically, to give the quality of life of the patient should be improved, even with that COPD. So mild to moderate COPD, initially gold guidelines in 2011, it was like they have, first of all, we confirm the diagnosis with our spirometry, assess the severity of airflow obstruction, then history of previous exacerbation. All these are combined together to give the proper COPD management. So in 2023, gold guidelines has actually changed. Initially, it was A, B, C, D based on the history, based on the severity. Now they have signified or highlighted the importance of exacerbations. So now we have 3 groups, A, B, and E, based on clinical symptoms, based on the exacerbations and severity. Severity of airflow obstruction has been removed. They have removed the severity of airflow obstruction. So that is actually, we are giving more importance to clinical findings, that is exacerbations. So inhaled bronchodilators, we have our beta-2 agonist. Like I said, long-acting beta-2 agonist, like salmeterol, formoterol. Formoterol, what is like in smart therapy, why we give formoterol? Because it has a rapid onset of action. It is same onset like our salbutamol. So beta-2 agonist, salmeterol, formoterol. Then inhaled corticosteroids, we can combine that. Among inhaled corticosteroids, we have budesonide, formoterol. Budesonide, as Subhankar sir has said, budesonide we can give because of the least side effects. And cyclosinide, as sir said, cyclosinide, it enters the lungs in inactive form. Then it is get activated inside the lungs by the enzyme esterase. Hello? Huh. So basically, inhaled bronchodilators, inhaled glucocorticoids, and methyl xanthines. These are actually non-selective phosphodiesterase inhibitors. They are actually plays a role in maintenance therapy, but long-term effect for COPD patients, we methyl xanthines, we should have a precaution because these have narrow therapeutic range. So whenever we give, the dosing should be at the safest level. So I will prefer to give the best effective low dose inhaled glucocorticoids along with inhaled beta-2 agonist, along with my anti-muscarinic antagonists like glycopyrronium or rather than tiotropium, I would go ahead with glycopyrronium.
So effectively, you have given everything. कुछ बचा ही नहीं. Nothing is left. So ठीक है, but ठीक है. COPD patients are those who have persistent bronchospasm. You actually have to give in everything. Then only they will come back to you. Otherwise, they will go from Dr. Nisha to Dr. Sakshi to Dr. Abhishek. This will keep on happening. But Dr. Sakshi, all the Group D patients from Kerala have come to you to Hyderabad. Tell me how to manage Group D COPD.
Am I audible, sir?
Yeah, you're audible.
So, as Nisha ma'am has very beautifully described, that gold guidelines have now updated into the ABE category. Basically, why it is important is because they're more stressing on the exacerbations part. So, E category, we have LABA and the LABA combination, which is most common preferred treatment. Plus, you will add a ICS. Again, they have divided into the things which favors its use and which are against its use. So strongly which favors the use of a ICS in a group E category of a COPD patient is the history of hospitalization or exacerbation, as we all know, like more than one moderate exacerbation leading to hospitalization of more than equal to 2 moderate exacerbations. And then blood eosinophils more than 300 cells per microliter. And history of if a patient is also having a concomitant asthma, which is now called as COPD-A in the phenotypes of the latest guidelines, that is also an indication to add a ICS to a LABA-LAMA combination of the group E. And we all know like impact trial, ethos and the chronos trials, which have been already told by Abhishek sir, has already been, these are the trials which basically favor the use of the LABA-LAMA ICS in the COPD.
Sorry, Dr. Subhankar, I would like to ask you. A lot of trials are being mentioned over here. Now, would you have anything to highlight as far as COPD is concerned, as far as pharmacology or evidence base is concerned?
Again, little things left in my pitara. Every maximum has been covered, but still I will like to say a few things, sir. If there is no exacerbation, if there is no increase in eosinophil count, and patient is immune compromised, if these three situations are there, then our choice will be LABA and LAMA combination. Okay. But if someone is having high eosinophil count associated with exacerbations, then with LABA-LAMA, inhalational steroids will be added. Now, two important trials, one is ethos trial and another was impact trial. Ethos trial used LABA-LAMA and budesonide, and impact trial used LABA-LAMA plus fluticasone. The efficacy of both the steroids in reducing eosinophil count and exacerbation were equally same in long terms. No such differences are there. But I would like to summarize that if there is any little bit incidence of immune compromising status of the patient, we should avoid inhalational steroids, as incidences of bronchopneumonia is maximum. If there is no exacerbation, reduced eosinophil count, go with LABA-LAMA combination. That's all.
Right. So, but Subhankar ji, one very special part of your branch nowadays is pharmacovigilance.
Yeah.
So, what would you like to talk about the pharmacovigilance in these category of drugs?
Ravi sir, you have to give me 5 minutes for that.
Okay.
Okay. In pharmacovigilance, we have two type of adverse drug reaction. One is type A adverse drug reaction and the second one is type B adverse drug reaction. Type A adverse drug reaction is related to the pharmacological mechanism of the drug. These are known as A for augmented reactions. They are strictly related to the pharmacological actions of the drug. And type B reactions are known as bizarre reaction. They are not related to the pharmacological action of the or mechanism of the drug. LABAs and LAMAs are maximally having type A adverse drug reactions like long-acting beta-2 agonist, tremor, palpitation, tachycardia, arrhythmia, all are through beta-2 receptors, beta-2 receptor mediated mechanisms, and they are type A reactions, and they can be minimized by reducing the dose or discontinuation if fibrillation or arrhythmia is developing. So this is in our hand, we can control. Like muscarinic antagonists, they are also having type A reactions. Dryness, urinary retention, exacerbation of glaucoma, these are all related to muscarinic receptor antagonism. So we can also control these mechanisms by decreasing the drug dose. But the huge question lies, the huge question is what to do when there is type B reactions. Type B reactions, which are unpredictable, not related to the mechanisms of the drugs, are maximum with corticosteroids. Dry mouth, oral candidiasis, thrush, these can be prevented by MDI usage and proper counseling. But still, there are some adverse effects. We should be very cautious. Number one, hoarseness of voice, dysphonia. Previously, it was thought that steroid interferes with the integrity of recurrent laryngeal nerve. But rather, it was established that These are the dysphonia or the hoarseness is due to steroid-induced myopathy of vocal cord muscles, which is very dangerous. Insomnia, psychosis, osteoporosis, cataract, these are serious adverse reactions with steroids. The beta 2 agonist indacaterol is associated with severe rash, Stevens-Johnson syndrome, erythema multiforme type, 4 hypersensitivity reactions. And to prevent these adverse drug reactions, 6 questions we need to know. ये भी हो सकता है कि there is no type 2 type B reactions, we are over diagnosing it. Suppose someone is having insomnia and psychosis after steroid use for longer time. It may not be the side effect of steroid. There may be pre-existing psychosis in this patient. He is having pre-existing insomnia. So we should not dilute. And if you misdiagnose that this insomnia and psychosis is steroid induced, we discontinue the steroid and patient will devoid of beneficial effect of steroids. Okay. Or if we underdiagnose insomnia and psychosis is there, we are saying that no, it's nothing like that. It is we are misunderstanding. What will happen? The aggravation of the side effects will be severe in future. So we have to balance, we have to diagnose the type B adverse drug reactions. How we can diagnose? 6 questions. 6 questions and their answer. Number 1, suppose there is an evidence of steroid-induced myopathy. A patient is coming with hoarseness of voice after taking inhalational steroids for 18 months to 24 months. He is coming with the hoarseness of voice. Now I have to diagnose whether this is hoarseness is associated with inhalational steroid or that was pre-existing. How I will go through. Question number 1, is there any evidence of such type of ADR with inhalational steroid? I have searched Google databases and I have found many things, many cases. So +1, this question is verified. Number 2, temporal association. The side effect started after the usage of inhalational steroid. Question number 3, D-challenge. If positive, we have withdrawn steroid and after that hoarseness was improving. So D-challenge is positive. Number 4, we re-challenge. We continued inhalational steroid therapy and the hoarseness became severe. So re-challenge is also positive. Number 5, there is no existing disease before administration of steroid, like no vocal cord disease associated, there is no previous vocal cord disease or cancer, nothing is present. It started with only after administration of inhalational steroid. And last, question number 6, is there any histopathological evidence or serum biomarker? If there is myopathy, we can take blood and see creatine kinase level is mildly elevated or not to have an association. So if all the points are positive, then we will call this myopathy has a definite association with inhalational steroids. If 6 points are with us. Now what happens that histopathology and serum biomarker checking is not often possible at maximum times. But still, rest of the 4 questions are with us. Temporal association, evidence, D-challenge is with us. But we can't do re-challenge. Like if someone is having steroid-induced Stevens-Johnson syndrome, you can't re-challenge. The patient may go into toxic epidermal necrolysis and die. So you can't do re-challenge. You don't have any serum biomarker. You can't do. There are financial issue, ethical issue. You have only 4 things. 1, evidence. Number 2, temporal association. Number 3, D-challenge. And number 4, no pre-existing previous vocal cord disease. Then this category will be probable. Probable association of steroid with myopathy or steroid with hypersensitivity, jo bhi ho. The third category, last 1 minute, sir. Third category. There is evidence in Google and the databases. Number 2, temporal association. दवाई लेने के बाद symptom शुरू हुआ. Number 3, D-challenge. positive, rechallenge not possible, serum biomarker and histopathology is not possible, and there is a pre-existing vocal cord disease. Anything can happen. Any vocal cord disease is present. Then there is a question: is it due to inhalational steroid, or is it due to pre-existing disease? It is pre-existing exacerbation of some disease. In that situation, we will categorize the association as possible. 6 points matching, definite. 2 points are not matching, probable. Pre-existing disease is there, possible. And if nothing is there, unlikely. There is evidence, but डी चैलेंज में कुछ फर्क नहीं, डी चैलेंज पॉसिबल नहीं है, सीरम बायोमार्कर कुछ नहीं है, प्रीवियस कुछ डिजीज भी हो सकता है, टोटली messed up, then it is unlikely. So we can diagnose type B adverse drug reaction and take steps. Either we withdraw the drug, we decrease the dose of the drug, we can decide after diagnosing it. Thank you, sir.
Amazing. No, actually, this is one such story where you never care about it till it happens. Once it happens, and in every patient, you keep on looking for it. So this is very important, pharmacovigilance. And I think the way clinical pharmacology is now coming up, that is one very important aspect of inhalation therapy, antibiotics that we use, and a lot of exotic medicines coming up in the ICU also. So it's all very important. But then coming down to the essence of this particular webinar is ICS LABA. ICS LABA, there are a lot of hurdles in ICS LABA, not only our knowledge about how to use it, how to optimize it, but also inhalation therapy and convincing inhalation therapy. After convincing inhalation therapy is the correct inhalation therapy. So as a part of the terminal end of our webinar, I would now like to call upon Dr. Nisha that you explain it to every patient. So I would like you to demonstrate, if you have a DPI with you, that how do you demonstrate, how do you take a DPI properly? If you could please proceed.
Okay, sir. Sir, I tell my every patient to sit straight before this is nebulizer. Can you see? Can everyone see?
Yes, we can see.
This is dry powder. This is for dry powder inhalers, nebulizer machine. So I will ask my patient to sit straight and first empty the lungs completely. And then take one capsule and open the nebulizer and put inside this. And then close. Then it is actually a breath actuated inhaler. We have to take a fast and deep breath. As a strong breath we have to take and hold it for 5 to 10 seconds. I can demonstrate like, first, we have to empty the lungs, then hold it tightly. Hold it tightly for 5 to 10 seconds, then slowly remove the DPI and slowly exhale. So that is the way, and always tell the patient to re-examine whether the capsule is empty. Minimum 3 times of inhalation I suggest. If even after that 3 times of inhalation, if our capsule is containing powder, then again we have to repeat the same steps. Take a deep and fast inhalation, hold it for 5 to 10 seconds, and then slowly exhale. That is the way. And after using these inhalers, we have to wash our mouth and throat. That is, rinse or gargle and expectorate the rinsate in order to prevent the local side effects like oral candidiasis, like we already mentioned. So this is the way I used to explain, and every visit I used to recheck the technique, whether they are doing the same way I taught them or not. So reassessment is very important, and their compliance is also very important. I hope everyone understood.
Yeah, definitely. You demonstrated in a very, very simple way. From my end, I would like to demonstrate this turbo haler, how you use it. You just simply means it's very simple to use. I hope it's visible. So you just rotate it once and twice, keep it straight, exhale. The whole process goes on for 10 seconds of inhalation, and then you slowly exhale through your nose. So this is how, apart from what Dr. Nisha explained regarding the DPI, this is also a breath actuated device, but this is how a turbo inhaler works. We also have several different available devices which are specialized, which are also to be taken by the same principle. But like everybody has told, demonstrate it at every visit. Ask the patient to gargle subsequently. Like Dr. Subhankar told, watch for side effects and be very careful. Now, Dr. Sakshi, I would like you, if possible, to help us demonstrate a metered dose inhaler. How to take it? What is the correct technique? You're mute, unmute.
Yeah, sure, sir. So first of all, I'll just tell you what has to be done, then I'll demonstrate it. As Nisha ma'am very nicely told, and only the problem with the DPI will be the capsule is moisture sensitive. So nowadays we are coming with the HPMC capsules also, which are very hygroscopic in nature with a less moisture content. Now talking about a MDI, which we all know is a pressurized suspension of the micronized drug particle. Now basically what a patient has to do is you have to take exhale out first. It is said that you exhale out up to the functional residual volume. Then you take the problem with the MDI is the coordination. So what you have to tell the patient is as soon as you start taking the deep, as soon as you start taking the breath inside, within the first upstroke, you have to activate your breath. So this coordination is basically, which is very essential whenever you're using a MDI. And then you have to stop your breath for 10 seconds and then let it exhale. So I'll just demonstrate it once. And one more thing, the priming of the inhaler is very important, which I forgot to say. So whenever you are taking a new inhaler or you haven't used your inhaler for 4 to 6 days in a week, try to prime your inhaler first. What has to be done in priming is you just, first shake your inhaler and just leave it in the air. Just release the dose in the air. Don't worry, it is not going to affect your dosage of, the wastage of the drug will not happen. So just you have to leave it in the air, 2 to 3 doses, you just have to let it go in the air. Then again, shake your inhaler. I'll just first tell you what has to be done. So put it in the mouth, try to seal it completely with your lips, little do the extension, press it, activate it. As soon as you start taking the inhalation, hold your breath for 10 seconds and leave it. So I'll just demonstrate it once. Shake the inhaler, put it in the mouth. This is how you have to take a MDI. And this is very important that you rinse your mouth whenever you're taking a corticosteroid containing MDI. Again, Gina has also said when you are using a as needed low dose of ICS formoterol, there is no need of mouth rinsing also. This is the latest one which has come up in the Gina 2023 because they said that as needed doses do not cause more of the oral thrush or candidiasis.
Very nice. Very nicely demonstrated. Another thing which I feel you could have touched upon was the use of spacers with the.
I have the spacer as well, sir, if you want me to demonstrate.
Please do demonstrate. You see, this will be there on YouTube for reference, and this is very important. I think this is the most important part of the webinar. Please do demonstrate how do you use it with a spacer.
So spacer are also called as the holding chambers, or they're also called as a wall holding chambers. I'm not promoting some like a brand of this spacer. So we have multiple spacers in the market. Here you can see the wall which is there. Okay. So now the space is why we basically use it to prevent the oral deposition. Now, point with the MDI is that you have to take a gentle and a deep breath, which is contrary to the DPI. DPI is rapid and a deep breath, whereas MDI is a gentle and a deep breath. Why it is thing is when you take a rapid and a deep breath, it gets deposited by impaction, causing the oropharyngeal deposition, which happens. So to prevent that, try to use it with a spacer, specifically for the older people, elderly people, and the children who are having a problem with the coordination. We should use the spacers. And again, this have multiple, different volumes are available for the spacers also. We have low, medium, and high volumes devices. The medium ones are the better ones, which have the 250 to 300 ml of the volume. So demonstrating it, what you have to do is, you have to put your MDI on this end of the, everybody can see, on this end of the, spacer. Again, the process is same. You have to activate it and take a deep inhalation. Point is, there are two types of method. One is a tidal breathing method. One is a single breath method. So single breath is you activate it, take a deep breath, hold your breath for 10 seconds and let it go. Whereas the other one who cannot hold your breath, as I said, the elderly and the children, so they can take 3 to 4 times the tidal breathing in the spacer. So I'll just show you. First, I'll be showing the tidal breathing method. So this is 3 to 4 times. You have to just do a tidal breathing and let 3 to 4 times the breath go in and out so that you can inhale the drug properly. Other is the single breath method. Again, 10-second pause and just a single thing. One more thing which I would like to stress is you can just water wash your spacers or with the mild detergents as the guidelines say and just let them air dry. Don't clean it with the cloth or something because that will cause the static charges to accumulate, causing the drug to get accumulated in the spacer itself. So cleaning of the inhalers and all is very important. Even the MDI mouthpiece should be very much clean and make sure that you clean your device as well.
Excellent demonstration. Very, very practical, much needed, because this is where the faltering happens. We unnecessarily blame the inhaler while it is the technique which is faulty. So, like Dr. Nisha demonstrates every time, Dr. Sakshi has demonstrated perfectly. Abhishek, now we are really we are going to wind it all up. I would like to ask you to give a take-home message regarding today's choice of ICS, LABA, and all these babas that we have discussed. What is your take-home message for us?
So my take-home message would be that in an asthmatic patient, we have to give an ICS LABA upfront. And in a COPD patient, we'll first start with the LAMA, go on to a LABA-LAMA combination. And then in group E, if it's a frequent exacerbator of the eosinophil counts of more than equal to 300, we add inhaled corticosteroid to it. And this is very important for everyone to remember. Never start with an ICS LABA in a COPD patient and never start with the LABA-LAMA combination in an asthmatic patient. Number one. Secondly, the choice of the inhaler. See what your patient is comfortable in, whether he's comfortable in a DPI or an MDI. Ensure that the technique of the MDI or DPI that he's taking is adequate before labeling him as a difficult to treat asthma or a severe asthmatic patient, because 99% of the time, believe me or not, the technique is wrong. You have to teach them, ask them to teach it back to you. You have to see that they're doing it correctly every time that they visit. So the only message that I would want to give to you today is there are a plethora of ICS LABAs that are available. I guess the panel, especially Dr. Ravi, has helped us summarize each and every evidence that we have with you in a very precise and beautiful way. We've also demonstrated how to use the inhalation device, the MDI or the DPI. And we've also emphasized with all our audiences here today that it's very, very important for you to ensure that the patient is adherent and is using the correct technique. And that's all that I have to say.
Excellent. Dr. Subhankar, anything you would like to add at the end? आपका 2 और 2, 5, 2 और 2, 6 तो अमर हो गया. It's like too good.
Sir, to my colleagues, my juniors and my seniors, I would like to request, please go to Google Play Store. There is an app known as ADR PBPI app, Adverse Drug Reaction Pharmacovigilance Program of India. Kindly download the app. Adverse Drug Monitoring Center is not present everywhere. So if we are finding any type of type A reaction or type B reaction, this is a very simple app. You go through the app, go through the points, fill the ADR form and send it to IPC, Indian Pharmacopoeia Commission, Ghaziabad, so that we should know about the type A reactions as well as type B reactions which are happening with this all the medications. Type A reactions are mainly due to not our fault, but we can control the type A reactions as these are related to the pharmacological mechanism of the drug. Type B reaction, the bizarre reaction, the gray line, if the incidence is increasing, then we have to step in the gray line. Please report so that if leads are more and more getting generated, a black box warning can be issued for a particular type B reaction for a particular agent. Maybe it's LABA, maybe it's LAMA, maybe it's ICS. That's all.
No, excellent. Really, was some really amazing things came out of this webinar. Now, one thing is, Dr. Subhankar, the way that you have justified ADRs happen, type A, type B, report them. Most of the time, as clinicians, if ADR it happens कि मैंने नहीं किया था, pharmacy वाले ने गलत दे दिया, अरे कुछ तो भी है. We are just running away from the fact. But we need to be very clear कि yes, these things happen and we need to report them. So, just in a quick line, Dr. Nisha, any take-home message from your side?
Sir, I would suggest especially all my juniors, go clinically, ask about history of irritable respiratory symptoms, and confirm the diagnosis before giving any inhaled corticosteroids or bronchodilates. We have to confirm the diagnosis by performing spirometry at least. Okay, then always check the adherence and check the technique. And apart from all those side effects, tell your patient that all these benefits outweigh the risk or outweigh the adverse effects. So this is going to be the cornerstone in the treatment part of your obstructive airway disease. Apart from pharmacological treatment, non-pharmacological approaches like avoidance of triggers for COPD, especially smoking cessation. And coming to that, vaccination also play a very important role, especially for COPD patients. We should advise them to go ahead with pneumococcal vaccination that will prevent further exacerbation or lower respiratory infections, at least prevent the severity. Pneumococcal vaccination, influenza vaccination, recent gold guidelines have shown that Tdap vaccination and even shingles vaccination, we should advise our COPD patients. So non-pharmacological methods also we should give some ideas regarding that to our patients. That is my take-home message.
Excellent, Dr. Nisha. You have really impressive way that you explain things and the way that you practice. Really, hats off to you, and your patients are very lucky.
Thank you, sir.
Dr. Sakshi, now I saved your take home for the last because it was your basic query that started it. I don't know how much you have been able to justify your query, but in this plethora and galaxy of LABA ICS, tell us, take home, what is your take on it? What is your final say? Unmute.
Before we wind up, sir, I want to ask you and the other panelist members, which is the best ICS LABA LAMA I should use? Honestly, because there are so many trials and I have been seeing through when you told me about this webinar, which you are trying to do. So which is the best one? I would like to ask all the panelists to give their talk as well. Their opinion and let me know which is the best one. Because honestly, with the so many trials, I'm still myself confused even today also, which one I should use.
No, but I'll tell you one thing. Your question per se is very difficult because if you say there is no head-to-head comparison per se of a lot of things which are there, but all of them have been proven by randomized control trials to benefit the obstructive airway disease in some way or the other, and all of them fall into the category of recommendation by GINA or GOLD. So I think again, we cannot mention any single thing in a go. Category-wise, molecule-wise, there can be individual selection also, but special cases like small airway diseases which have to be taken care of, which has been explained by Dr. Abhishek sir very well. Even I would like to exclaim Dr. Tridip Chatterjee sir from Mumbai, Dr. Jayaraman, Dr. Anand, Dr. Mallikarjun, all of them are asking us, and Dr. Tridip sir is very in a detailed way told us about the use of single inhaler. So I'm telling you, it is really a difficult question to answer because everything is there in the market for us to make a choice. I personally feel it will be more of a clinical judgment rather than a single recommendation. But again, I allow Dr. Nisha and Dr. Abhishek to tell a line to what Sakshi wants to know. Dr. Abhishek, please, anything you would like to recommend?
So, Dr. Sakshi, basically, we all know that fluticasone is a much more potent inhaled corticosteroid than a budesonide is. But we go with the budesonide because the chances of having pneumonia with the budesonide are much less than that with a fluticasone. Then again, as far as formoterol and salmeterol have been concerned, a number of head-to-head trials have happened, and we've seen that both have similar efficacy and a safety profile. The combinations that are available in market are mostly with a formoterol and a budesonide or a salmeterol and a fluticasone. So what generally we do is we start with a formoterol and a budesonide as it's been recommended by GINA, because formoterol has a rapid onset of action and can be used as an SOS basis. Salmeterol has not been indicated for that. Secondly, if an asthmatic patient is not being, the symptoms are not being controlled, even with a high dose of formoterol budesonide, you can give a trial of a fluticasone containing compound, and with the caveat that it can cause pneumonia. But as far as COPD is concerned, I would recommend that we always use a budesonide, a combination. Rarely go to a fluticasonide combination, even if it's not helping with the exacerbation of symptoms, because the COPD phenotype of our patients are much more prone to the development of pneumonia. So we'll have to be careful in that aspect. I hope I've answered your question.
Very much. In fact, you have summarized the whole webinar in your this statement very beautifully. Dr. Nisha, short answer. You give long answers. I want just a short answer to Sakshi's question. Unmute. Just answer your question shortly.
Sir, like Abhishek sir said, formoterol, I usually prefer formoterol budesonide glycopyrronium, because formoterol rapid onset of action, budesonide lesser chance of pneumonia, like studies have shown, and like Subhankar sir has said, so much advantages for glycopyrronium over our tiotropium and all those things. So I prefer formoterol glycopyrronium and budesonide. That is my personal opinion, but many researches are going on till we don't have a conclusion.
So I think Dr. Sakshi, I don't know howsoever we have been able to actually answer your query, but maybe we have been able to discuss and highlight the important aspects of a lot of common medicines that we are using. So at the end of this very interesting webinar, I would like to thank my respected panelists, my colleagues. I would like to thank CIPLA and the webinar team. I would like to give a big thanks and a lot of blessings that we got from Krishna sir. CVK sir has really contributed extremely to our webinar success, and I can never stop without mentioning the name of Dr. Atri, Dr. Shivani, and Dr. Kirat, who always contribute immensely to the success of these CCI webinars and keeping them relevant. Tomorrow, I live in Indore. Ujjain is nearby. Tomorrow is Mahashivratri. I would like to wish all of you a very, very happy Mahashivratri and International Women's Day. Thanks to all of you for joining us on this beautiful night. And I would like to wish you a goodbye from CCI. Thank you.
Thank you, sir. Thank you so much, sir.
Thank you.